Welcome to our panel discussion. Today we will review the findings of two important studies published earlier this year in JAMA, the Journal of the American Medical Association, and we will share our thoughts on how these studies have an impact on patient-centered care. I'm Mike Coburn, professor and department chair for the Scott Department of Urology at Baylor College of Medicine in Houston, Texas. Joining me on this panel by phone are Dr. Ronald Chen, Associate Professor of Radiation Oncology at the University of North Carolina School of Medicine in Chapel Hill, North Carolina, Dr. Daniel Barocas, Urologic Surgeon and Oncologist and Associate Professor of Surgery and Associate Professor of Medicine at Vanderbilt University in Nashville, Tennessee, Dr. Frank Domino, Professor of Family Medicine at the University of Massachusetts Medical School in Worcester, Massachusetts, Ralph Conwell, a patient and prostate cancer survivor, and Sarah Dougherty, Senior Program Officer at PCORI. And here with me today are Todd Kielman, who is an instructor in urology at Baylor College of Medicine and a very experienced physician's assistant dealing with urologic patients, and Lisa Eichard, who is a practicing nurse and nurse manager in our Department of Urology, also with great experience in dealing with patients with prostate cancer and many other urologic conditions. I'd like to draw your attention to the two other presentations in this CME activity. Those presentations by Ron Chen and Dan Barocas go into greater detail about the findings from these important studies. So to get us started, I would like Ron Chen, the author of one of the two studies, to give us a brief overview of the study's findings. Ron?
Great. Just to kick us off, I think I would like to put the results from Dan's study and my study in context of the treatment paradigm for prostate cancer. It's important, I think, for the listener to know that prostate cancer is grouped into different risk groups, low, intermediate, and high risk. And according to the most recent American Urologic Association guidelines in 2017, low-risk prostate cancer, which is the very earliest diagnosis, the preferred recommendation is active surveillance or no treatment. But for patients who have more aggressive prostate cancer, intermediate risk or high-risk disease, patients are recommended to pursue either surgery or radiation. And these two studies provide patients information about the quality of life impact of surgery and radiation compared to active surveillance. Specifically, we looked at four different domains of quality of life, including impact on sexual function, urinary leakage or incontinence, urinary irritation, as well as bowel symptoms. And these two studies looked at modern surgery, mostly robotic surgery, as well as modern radiation, either IMRT or brachytherapy. And just as a very quick summary, the studies show relatively favorable quality of life outcomes of modern treatment compared to active surveillance. The studies did find that in terms of sexual function, surgery is associated with a somewhat worse sexual function compared to active surveillance, as well as worse urinary leakage. Radiation is associated with more short-term urinary irritation as well as bowel issues. And I think for patients who have the diagnosis where treatment is indicated, these different types of quality of life impact of the different treatment options can help patients think about what treatment they would like to pursue that meets their preferences.
Excellent. Well, thank you, Ron. Thank you for the summary. We appreciate your perspective, obviously, as an author and an expert in the field. I'd like to now turn to Frank and ask you, Frank, to comment from your perspective as a primary care physician. How do you view the importance of these studies, and how do they impact on how we work with patients in the process of shared decision-making?
Mike, thanks for asking me to comment. I believe both of these studies help me as a primary care provider, someone who sees patients and counsels them on the pros and cons of screening for prostate cancer, how to decide when it looks like a patient does have cancer, how best to treat it. Both of these papers are helpful in that they evaluate not only the outcomes of the cancer, but more importantly, some of the areas, the adverse events and complications of treatment. It's my sense that most patients, when you give them the diagnosis of any chronic condition that's life-threatening, they look to try to find what is the shortest path to receiving the best benefit. And when you have cancer, especially a solid tumor cancer, patients' first inclination is to cut it out. Both of these papers, while commenting on what might happen had you gone aggressively with a radical prostatectomy or taken a slightly more conservative approach with regards to radiation treatment, demonstrate that although there may be some adverse risk associated with any aggressive treatment, it needs to be balanced with what most of us call active surveillance, or closely following patients without implementing a treatment, but rather rechecking their blood work, rechecking their physical exam, rechecking their symptoms on a fairly regular basis. Having this information from these two papers allows me to pull out real numbers to help patients in their decision making. That being said, most patients have a high level of anxiety with regard to having a cancer and often will side with aggressive treatment because they almost always have an intuition that that's going to lead to the best outcome.
Well, thank you, Frank. We very much appreciate your thoughtful analysis. So, Ralph, would you like to provide the patient's perspective on how shared decision making is impacted by the data from these studies?
Yes. Um, Frank, thank you for what you said, and that is that's definitive of how a patient feels. I agree totally that the patient goes out and tries to find the shortest path, but also the desired result based on their preferences, because all of us different patients have different preferences, and so as a result, the younger guy with prostate cancer, of course, is probably going to protect his sexual function more than someone 75 years old finding out they have prostate cancer. But what you stated to me is dead on. I mean, that is exactly what we do. But we do tend to find the shortest path to getting it out sometimes. I think that's the mistake that a lot of patients make, is they do things that they don't need to do because they cannot reconcile the fact that they have cancer with the fact that they don't have to have it removed. Because for most patients, including me, and patients that I've talked to, your first reaction to hearing the doctor say you have cancer is to get that cell out of me as fast as you can and as far away from me as you possibly can, because I don't want to deal with this again. And so it leads a lot of patients to make decisions that they don't need to make. And I think this is where the USPSTF got involved in this thing, is because patients were making the wrong decision based on the information that they had, simply because the patient does not understand the implications of a low risk or low medium risk prostate cancer diagnosis.
Ralph, I appreciate you bringing up a key point there. And you mentioned age and possible changes that people make based upon where they are in life and what their future looks like. When I'm helping a patient try to decide how aggressive to be with a treatment, one of the many things that we try to bring into perspective is life expectancy. And so if you're a healthy 75-year-old, you probably have 15, 20 years of life expectancy. And I like to remind patients that it's not just about dying, it's about living a good quality of life. Sexual function is one issue, so is urinary incontinence, and so is persistent bowel dysfunction. So I do bring those issues up when I counsel patients, but I also ask them how they're going to feel, how they can project how they feel if they had surgery, and let's say they had no complication. Would that change a great deal if they had a complication like a loss of sexual function or an alteration in sexual function. I say most people do fine if they have surgery, but a subset will have persistent incontinence and they might need to wear a diaper the rest of their life. Is that something that's important? I also think, and Ralph, you brought this forward, is sort of the risk of death, and I think that's everyone's fear. And while that becomes foremost, these two studies remind us that mortality is an important outcome in most people's minds when they hear the word cancer. But in a disease like prostate cancer, especially if it's low or intermediate risk, it is the complications that should help them focus their decision. And I, as a primary care provider, look to my peers in urology to help the patients understand that it's not all about just living and dying, but it's about living a quality of life that they want to live. So I guess my thoughts would be to hear from both Dan and Ron about how they recommend helping patients clarify in their mind which morbidities they might want to risk and at what cost.
Dan, please go ahead.
Sure. I think, again, very interesting discussion, and the perspectives are really important. I think one of the key things to recognize is that our studies have relatively short-term outcomes, 2 and 3 years, 2 years at the UNC study and 3 years at our study. And the main outcomes are the harms of treatment, the side effects. Any shared decision-making process should include not just those harms and side effects, but also the potential benefit in terms of controlling the cancer, and also the patient's perspectives and priorities, and also the spouse or partner's priorities and preferences. And so there are actually many components that go into the decision, and our data help to inform one of those components. It's a key component, but it's only one. I think one of the complexities here is that the data for one of the other key components are not perfectly clear. So the oncologic benefit of treatment has not been worked out perfectly. The studies that we have are fairly limited in terms of their applicability to the cohort that we see today and the treatments that we use today. And so it lends a lot of complexity. In addition, there's a wide range of risk that we see. So I agree completely, wholeheartedly, 100% that most men with low risk cancer are best served with observation and not with treatment, because it preserves the quality of life. And, you know, in that setting, in most cases, the treatment is worse than the disease. And the patient should be informed of that long before we have a discussion about their pathology. In other words, at the time of biopsy, or perhaps even the time that we're drawing a PSA, the patient needs to understand that most men will have some small amount of microscopic low-grade prostate cancer at some point in their life, and that those are not the ones we're looking for to treat. If we find one, we're just going to watch it. So that way they're not terrified and surprised when you inform them about their pathology report, and they don't rush off to treatment. I think that's actually very important. But there are higher risk cancers where the risk of progression is quite real. And in those settings, we do feel like treatment is probably beneficial. And there are some studies that have borne that out. So I think we have to bear that in mind when we start informing patients. It's not simply that the harms of treatment are bad, so we choose surveillance. It's the harms of treatment can be significant, but we have to balance that against the risk of progression and the patient's own preferences. One of the interesting things, both in Dr. Chen's study and our study, is that a lot of men in the age group in which prostate cancer is diagnosed already have existing erectile dysfunction. And so that turns out not to be a priority for up to 40% of men who are diagnosed. And so that's an interesting component that we figured out here. I do hope and agree that these data can be used constructively to facilitate and inform shared decision making. My only concern is that since we've only elucidated this one component, that it be conveyed that treatment has bad side effects, so you shouldn't do treatment. And I think that would be a mistake for men with a long life expectancy and higher risk cancer who may really benefit from treatment and have to accept some risk of side effects to get that benefit. And I guess I'll stop there and hand off to Dr. Chen so that he can have some input as well.
And thanks, Dan. So, in our study, although this is not part of the JAMA paper, we actually asked these over 1,000 men we surveyed what their priorities are, and overwhelmingly the number one and number two priorities were cure and quality of life. And for many men, actually quality of life was one and cure was two, and for other men, vice versa. And so I think these really are two of the most important issues for people who have newly diagnosed prostate cancer. And the papers from Dan and our group hits on this quality of life issue, which I think is a very important issue for most men who are diagnosed with this disease. And I think the important thing about these two papers is that the treatments have evolved quite a bit over time. And so the impressions patients may have about the quality of life impact of surgery and radiation, and frankly, the impressions many physicians have about surgery and radiation, their impact on sexual function or urinary function, are probably no longer correct because of how much these treatments have evolved. And surgery, the robotic surgery, is now much less invasive than it was in the prior generation. Radiation is also much less invasive in the sense that it's a lot more targeted and there's much less organs and bowel being irradiated. So I think these two papers can update information for patients and physicians on the quality of life impact moderate treatment options may have on the prostate cancer.
I think what both men just said, both doctors just said, Dan and Ron, are so important to the patient, because if you start this discussion before the biopsy with them on the fact that there are different, I don't know, call it levels, different levels of prostate cancer where you have different choices and different decisions that you can make. And start that conversation then. If you start the conversation on diagnosis, we can't hear you because our minds are on, am I going to die from this? That's just where a lot of men's minds go immediately when they hear you have cancer, because they've had so many relatives that had a miserable life or a death outcome with cancer. And I think that point is so critical. And to what Ron said, talking about these things in advance, so EBRT or RALP for radical prostatectomy, to have at least some of those discussions, and primarily a piece of paper, a pamphlet that you can hand to the patient, and when they go home, because when they start talking about this cancer business, we get frightened and we can't even remember what you guys said when we get home. But if you gave them something, a clear statement of here's active surveillance, here's radiation, here are different forms of surgeries, that is so critical to a patient in that early stage, and I do believe prior to the diagnosis would make a huge difference in the choices that are made.
This is Frank. I'd like to ask, I appreciate that last comment from Ralph, and I'd like to now make it very specific. I'd like the help from Mike and Ron and Dan. I have a patient who presents to me after receiving their diagnosis, and they're not very low or low. They're at an intermediate or a high risk. Their Gleason scores are 7 and or above. What are the key things you want me to help my patient understand as they try to make this decision? And in particular, about what Ralph said, how do I structure the discussion about will you be cured? Because we know that these papers help us understand a bit about quality of life. But how do you want me to structure? What kind of messages do you think I should be conveying as patients go to make this decision? And I do want Ron to be involved in this because I think we think of surgery. Patients think of surgery. That's what they're asking us for. So I'd be curious what sort of key points you want me to address, especially with regards to the intermediate or high risk patient.
So I think I'll start, and this is Ron here. I'll give you my perspective. I think the question about intermediate and high risk, I think it's really relevant because as we've discussed already, for most patients with low risk cancer, active surveillance really is a good option. It's not the only option, but I think as somebody who has been involved in writing some of the guidelines on prostate cancer for ASCO as well as AUA, I think most of the guidelines do favor active surveillance as a good option for low risk cancer because low risk cancer is slowly growing and active surveillance is the best way to protect somebody's quality of life. So for intermediate and high risk, I do think most guidelines would, certainly high risk and intermediate risk usually also, the guidelines usually favor treatment unless somebody has a very limited life expectancy. Honestly, if somebody has a very limited life expectancy, they probably shouldn't have had a PSA check to begin with. But if they have a life expectancy and they have intermediate high risk cancer, most guidelines would favor treatment instead of active surveillance. And most of the treatment options involve surgery or various forms of radiation. I think to me, I usually advise patients to have with any cancer, to have a second opinion. They usually should talk to multiple providers to hear about surgery directly from a surgeon. And I advise patients to hear about radiation, the various radiation options from radiation oncologists. I think patients should make an informed decision once they've heard about the options, when they've heard about the pluses and minuses, the side effects of the different options available to them before making a decision. And I think even with high risk cancer, there is time to get a multidisciplinary consult or a second opinion before jumping into a treatment. And so I think multidisciplinary care for patients is good in cancer, and that applies to prostate cancer as well.
So this is Dan. I agree with Ron completely, and I was going to say something similar, which is that anytime I've diagnosed somebody with an intermediate or high-risk cancer who's contemplating treatment, they meet with me and a radiation oncologist. I think it's important to get both perspectives on that and to make a really good decision. In other words, they're going to live with the results of this decision for the rest of their lives, and hopefully it'll be a long life. And they have to be comfortable and confident that they've been fully informed before they dive in. So that's one issue. The other issue is the discussion with the patient is long and nuanced. There are a lot of components, as I talked about before, in terms of emphasizing harms, explaining the expected benefits, and eliciting the patient's preferences, and sort of helping to communicate with them and coalesce all these moving parts into a good decision. Regarding the discussion about expected benefit, what I think I would value from the primary care provider's perspective is to have a patient coming in who is prepared to recognize that we don't know the best answer. If we knew the best answer, we would do the same thing every single time. We believe there is equipoise between treatments. In other words, that surgery and radiation have about the same likelihood of preventing progression. And in that light, many men end up deciding based on the convenience of the treatment or the side effects. Now, that being said, there are nuances, and there are patients in whom we would steer them toward one or the other treatment, either because of their anatomy or because of the severity of disease and risk of progression, because a patient does or does not want to layer on hormone therapy on top of the radiation, or can't for other medical reasons, and so forth. So there are nuances to this discussion, but I think starting from the point of, sir, you have a cancer that probably should be treated. Any treatment we do is going to have some degree of side effects. And at least as far as we can tell, the treatments seem to work pretty similarly in terms of their effectiveness. And that's, I think, the starting point for the discussion. And then encouraging them to hear out the options and weigh them thoroughly before jumping into a treatment.
Now, when you say treatment, do you include in that broad term watchful waiting or active surveillance, or are you stating more surgery versus radiation?
I think, as Ron pointed out, most men with a long life expectancy who are diagnosed with a high-risk cancer, or many of men with an intermediate risk cancer, should consider treatment rather than an observation pathway. And again, that's a nuanced discussion where you can calculate, the risk of progression for a particular patient and arm them with that information to make a decision as to whether they want to watch it or treat it. I include active surveillance as an option and promote it actively for men with either with low risk cancer, very favorable intermediate risk cancer, or a shorter life expectancy. Or again, sort of the nuanced aspects, somebody whose anatomy or medical history precludes safe treatment and where that treatment might carry extra risk. I also would emphasize more the surveillance pathway.
At this point, I'd like to turn to our colleagues, Todd and Lisa. Todd, as I mentioned earlier, is a very experienced urology physician's assistant, and Lisa, a nurse manager in our urology clinic, and ask how you view the results of the studies and how they have importance for you in the manner in which you interact with patients, and the whole patient-centered care model.
Thank you very much, Doctor. So I found the studies to be very enlightening in regards to the options that were available. Having read through it, and I know that when patients come in to see us, and we're going to end up doing a PSA, a prostatic specific antigen test, that typically that's going to be a patient education appointment anyway, and so we're going to be educating them a lot on what's going on and what the test results may mean, and what their options are going to be afterwards. And these two papers have really kind of opened up and illuminated what all those options are and what some of the effects could be from that. And so it's really given the primary care provider a lot more tools in their belt to use during that appointment.
Excellent. Well, thank you, Todd. Lisa, what are your thoughts?
To add to what Todd has said, I think these papers were very informative from a nurse's perspective. We have a very special relationship with the patient. Oftentimes patients will call when they're making their appointments with their urologist and they've had a diagnosis of prostate cancer, and immediately they have questions and concerns. So I think taking the information learned, we can help to educate the patients that they do have options available to them, and educate them as far as, in our experience, what other patients who have had the same diagnosis, how they've fared with their course of treatment.
Well, Lisa, Todd, thank you so much for your input. We certainly are very supportive of the key role that our advanced practice providers and nurses in the clinic play in counseling patients, and we appreciate your interest and your comments about the importance of these studies. Todd, do you have any comments or questions for the previous panelists?
I do. Actually, I had one concern that I had was reading through the studies and the papers, and it talked a lot about doing active surveillance, which I know is a more common treatment these days. However, in the primary care setting, it seems like it's going to be a difficult discussion to have with a patient where you're telling them, or they're coming back to you with a diagnosis of cancer, and you're basically telling them that we want to put them on active surveillance, and opening the discussion of, you have a diagnosis and we really want to do, in their mind, nothing. And so or do we have any suggestions on how we broach that subject and kind of move forward with that with them?
Yeah, it's a very important question. Any comments from our other panelists in that regard?
I can help with that one. This is Dan. I think it's important to consider not just the harms of treatment, but also the risk of progression of the cancer. And as Dr. Chen explained at the beginning of this segment, for low-risk cancers, active surveillance is really an appropriate choice because the risk of progression there is very low, and we know that active surveillance is the best way to preserve quality of life. And in fact, if you look back a little ways here, I think what was really hampering our ability to do the best for our patients in the past was the instinct to treat everybody who was diagnosed with prostate cancer, rather than being judicious about thinking who is likely to progress and who is not. So I think the discussion is quite nuanced, and both the treating doctors, the urologists and radiation oncologists, as well as the primary care providers, can help the patients understand that there are trade-offs being made here, that when you have low-risk disease, if you go for treatment, you're taking on quite a bit of risk of side effects without much evidence of benefit. On the other side of that coin, if you have high-risk disease, or in some cases intermediate risk disease, there's more of a trade-off between potential benefit in terms of stemming progression of disease versus potential risk in terms of taking on side effect risk. I think in the past we were treating everybody who came along, and this was the problem when the U.S. Preventative Services Task Force gave prostate cancer screening a D recommendation in 2012. What they were reacting to in large part was this over-treatment of men with low-risk disease, subjecting them to the side effects of treatment without likelihood of benefit. And I think what changed the minds of those on the U.S. Preventative Services Task Force when they came out with their recent recommendation change to a grade C, one of the things they enumerated that changed their minds was demonstration now that we are doing better at separating diagnosis from treatment and being more judicious about observing men who have low-risk cancers. And so, in the University of Michigan has published a paper about the state of Michigan showing that up to 50% of men with low-risk cancers are now undergoing initial observation, and we see the same thing nationwide as well. So I think those conversations are really important. And from my point of view, from the point of view of a urologic oncologist at a tertiary care center, it's much easier to counsel a patient about active surveillance if they've heard of it before. If they've only heard of it after a diagnosis of cancer, it's actually hard to talk them out of treatment. But if they've heard about it in the setting of PSA testing, in the setting of biopsy, that we often find cancers that we don't need to treat, then it's very helpful in counseling the patients and helping them to understand that some of these cancers are relatively innocuous and at least initially can be observed, and only if they progress would we intervene.
Well, I would ask Dr. Ronald Chen and also Ralph Conwell, our patient and prostate cancer survivor, if they would like to make any comments on the topic as well.
Well, I would on the thing that Todd said earlier about the patient having trouble reconciling the fact that you hear the doctor say you have cancer and then trying to reconcile that with active surveillance. That is such an emotional time for the patient in understanding the fact that prostate cancer cells are not like all the other horrific cancers that you've heard of and maybe watched relatives die from. You have to understand what's going on with your case specifically. You're not dealing with all the other cancers in the world. You're dealing with prostate cancer, and you have the ability to monitor this thing, and you have the ability to do that and know where you stand and not lose sleep at night by testing routinely and making sure that your progression is not moving toward being more aggressive. That is just a difficult thing for patients to understand. And at the moment of diagnosis, when they're talking to the nurses and the PAs, they don't know what to ask. They don't know how to ask, and they don't want to appear ignorant. At the same time, they don't know how to ask the questions. They don't know what's important at that point. They don't understand what's going on. And so it would be the thing that they're talking about, that time period of affecting the people who are true candidates for active surveillance is so critical, because I've known many patients who made decisions they didn't need to make because they did not understand what they were hearing.
This is Ron here. I do think that the medical culture has changed, and we recognize that low-risk prostate cancer is often a slow-growing disease, and active surveillance is an appropriate option. In my experience here at the University of North Carolina, when we see a low-risk patient in clinic and explain that it's a slow disease progress, it's a early diagnosis and favorable prognosis, and active surveillance is a safe option, I think many patients actually feel relieved, understanding that and understanding that they don't have to immediately go through treatment and have the potential quality of life impacts from surgery or radiation. And in fact, the majority of patients we see here at UNC with low-risk cancer, after discussion, will choose active surveillance. And I think that's also a trend that's seen around the country as well. And this is also where the primary care provider can really help in the discussion process and helping patients make the decision. On the flip side of this, I think it's also really important that patients who have a more aggressive diagnosis understand that active surveillance is probably not the best option for them. And I think in this particular discussion that we're having with primary care providers, collaboration as well, helping patients who have the more aggressive diagnosis understand that they are actually needing treatment and thinking about surveillance is not appropriate. I think this can really help patients make the appropriate choice.
Well, I now would like to turn to Sarah Dougherty from PCORI, which is the Patient-Centered Outcomes Research Institute. Many of our listeners may not be that familiar with the work that PCORI does in the area of shared decision making. And Sarah is here to provide some background and give us a sense of how PCORI pursues its mission, selects research projects, and addresses its efforts in research and dissemination of information. Sarah, please tell us anything you'd like to inform our listeners about.
Sure, thank you. So the Patient-Centered Outcomes Research Institute, also known as PCORI, is an independent, nonprofit, non-governmental organization in Washington, D.C. And PCORI was authorized by Congress in 2010 to fund comparative effectiveness research. So comparative effectiveness research, or CER, is the type of research that we've actually been talking about today with our panelists, that focuses on head-to-head comparisons of benefits and harms of commonly used medical interventions or strategies in order to be able to determine which approach works best for particular individuals. PCORI's mission is to help people make informed healthcare decisions by producing and promoting high-quality evidence that comes from research that's guided by patients, caregivers, and the broader healthcare community. This patient-centered research, which is what we call this type of CER research, is really a hallmark of PCORI, where patients and other key stakeholders are partnering with researchers throughout the research study. So I can comment briefly on the second part of your question, which was how we select various studies and perhaps why, even in the case of the two studies that we've talked about today, they were good candidates for our research funding. So from what I've heard from the discussion, there are three aspects that I think have been touched on, and I just want to highlight that are a part of these two studies that are also sort of commonly shared among other studies that we fund. The first is that Ralph Conwell, who has joined us today as a patient partner on one of these studies, is a part of the research team. So as I mentioned, this is one of the hallmarks that is required as part of PCORI funding, to include patient partners and other key stakeholders on the research team. And as you can see, he not only contributed to the design and the conduct of the research study, but is actively involved in the dissemination of the results. So at PCORI, we really do encourage this type of partnership because we believe that it will ensure that the research questions being asked are more meaningful and the results are more useful for informing healthcare decisions. A second aspect that I wanted to highlight that I think is important is that we really do encourage our investigators to consider a full range of outcomes that matter to patients and the people who care for them. So patients not only care about clinical outcomes, so in the case of prostate cancer, about recurrence and metastasis, but they also care about treatment toxicities and quality of life. And I think that's why these two studies are so important. And part of the reason why we're talking about them today, because these studies did emphasize the evaluation of the sexual and the urinary and the bowel outcomes, as well as quality of life, to be able to capture that full range of outcomes. And I think, as one of our other panelists had commented, when you have complete evidence, then you're able to consider the trade-offs that need to be made, to consider the harms and the benefits of the various options, and then align this evidence with the individual's patients and preferences and goals. And then the third aspect that I think is common to these two studies, but is also common for other studies that we fund, is that they were able to capture a real-world setting with a broad range of individuals that were a part of the study. So as our panelists had mentioned, these two studies were evaluating modern or up-to-date treatments that were used in everyday healthcare setting. And they also were more inclusive than traditional trials. So these two studies were more racially and clinically diverse. So the results are more generalizable to a broader range of patients. I do think your comment about shared decision-making is really critical, and I think that's something that PCORI emphasizes, and prostate cancer, these two prostate cancer studies really highlight the importance of shared decision-making, trying to determine what is best for the patient considering their unique status, preference, and goals, because we know that you're only able to make the right decision if you have good information that can inform your decision. So I think these studies, along with the other relevant literature on prostate cancer treatment, will really help men and their clinicians consider the full range of outcomes that matter to men with prostate cancer, so they can select the best option for their care.
Oh, I think that's excellent, very informative, and it's very helpful for our listeners to understand the important work of PCORI and how studies like this can be brought to the public's attention and to the attention of a wide range of providers to try to improve our ability to truly provide shared decision making in our practices. And I appreciate your comments, and we're very appreciative of PCORI's involvement and support of this type of effort and this type of educational program. Thank you. Well, I think this has been a very important and widely ranging discussion, and I hope that the result is that we have more information about the harms of prostate cancer treatment and the complex decision making that goes into selecting treatment, and also a stronger sense of the advantages and disadvantages of the different treatment approaches that are available. And that with this new information and with the important perspectives that we've heard today, that the whole process of shared decision-making involving the full range of providers and patients as well will be enhanced and supported I think that the usefulness of these studies and real-world decision-making really is very relevant, and we greatly appreciate the comments of all of the panelists to help us understand these complex issues better. So again, thank you to the panelists. We hope that providers of all types and also even patients may find this dialogue of support and value. So thank you for your participation. Thank you to our colleagues from PCORI, and it's been a pleasure to have you all with us. Thank you.